Hey everybody, my name's Curtis Rhodes. I'm the paramedic instructor at Gordon Cooper Technology Center. I'm with Dr. Melissa Brave here, and we want to take a few minutes just to talk about RSI, the nuts and the bolts of RSI. So first off, let's just introduce ourselves real quick. I'm a 18-year paramedic. I'm the lead paramedic instructor here, and I'm sitting with Dr. Brave.
Hi, I'm Dr. Brave. I did about 20 years pre-hospital care experience and then transitioned into the physician world, and now I work in emergency medicine, and I've been enjoying working with the technology center as well.
All right, so a couple of things we want to talk about is RSI and what is it and who is it needed for. So when you look at this, doc, who are you thinking about? Who is an RSI procedure? Who is that indicated for?
I think it's really important when you're in the pre-hospital environment to identify some categories that a patient would fit into, to say this patient fits pre-hospital RSI intubation. And I think you need to think airway. Does the patient have some impending airway catastrophe? And then I say, is it number two, the patient has an oxygenation issue that can't be overcome with some of the like BiPAP, CPAP, things that are available in the field? Does the patient have a ventilation issue, so they're retaining their CO2, they can't get that off without securing that airway, or they have some clinical course that precludes them from making it to the hospital for further definitive airway management.
Okay, so we've kind of talked about who is a good candidate for, and we haven't really went into the different mechanisms or whatever, but indication-wise we covered. So when we look at the nuts and bolts of RSI, we should go back to kind of our P's. That's where we were taught, and hopefully we've learned what our different P's are. We have 7 P's here listed for these patients. So tell me about preparation.
I think preparation is probably the most important step in attaining and being proficient at RSI. Number one, the pre-hospital environment is fighting somewhat of a battle to make sure that you can maintain the intubation skill even in cardiac arrest patients, let alone maintaining the RSI skill. I'm a big proponent and will always continue to fight to make sure that pre-hospital providers are able to use RSI as well as intubate their cardiac arrest patients. But you have to prepare before you get to the patient. So you have to be thinking airway. I used to always talk to my medics when I was a director, and it was, you need to think about airway the minute you show up to your shift to the minute that you walk away from your shift. And you always pick that up with each shift that you start. You need to think, how can I get better at airway management? What do I need to practice today while I have my downtime? And how do I prepare for this? Just to make sure that you can adequately perform the skill.
Yeah, so I think that's a really good point, because typically we think of preparation, and in this industry we're a really hands-on for this particular moment kind of thing, this one moment, all focused on this one task. But what you're saying is preparation really begins even all the way back to school, of recognizing who that patient is, as well as B, how to be able to do it, and recognize who is going to be hard for you to do.
Exactly.
So it's a really hands-on, even within the shift, of making it extra hard to get an airway. So then that preparation, much like you can relate it to a sports field, you know, when you've prepared on the practice field, once you get into a match, you're ready for it. So if you've prepared for that difficult airway, what you're saying is, when that difficult airway comes, you're ready for it.
You're ready for it. And you're also not amped up, because your adrenaline kicks in when you're in situations where you feel threatened, where you feel like you're unprepared. If you're prepared for this and then you train with the team that you work with, you know, your buddy knows you. And I watched the team building within our service as well, is that even the EMTs who are watching their paramedic partners and giving them feedback, they would do that on calls. And so their success rates would go up tremendously, just because they trained as a team. They functioned well as a team. Yeah,
that makes sense. And that's something that I've seen as well as a director, was an EMT take ownership of even the paramedic to make sure he is not going to botch that up, because they care for him and they've trained and they've been in the trenches, and they're going to make sure that if he forgot something.
Right.
So their preparation is important as well.
I mean,
right?
that's your recon buddy. That's the guy that's watching out for you while you're completely focused on that patient and getting that airway. So preparation, again, begins from the minute that you walk in on your shift, from the minute that you train together, from the minute that you check your equipment, that you make sure it's functioning, taking ownership of the performance that you're going to make
Yeah.
is key in order to keep this skill.
Okay. So, positioning. I know this is going to be a really big point, really important point. Tell me about that.
Yeah, positioning's 9/10 of the law of getting a tube in, honestly. I can make an intubation look quite easy. I've had some services who brought some patients in, and they'll tell me the difficulty, and I'll make a few adjustments of the patient's position, and I can make it look easy. But it's just from understanding that positioning is 9/10 of the law. If you can get that patient into an adequate position, and when I say that, what I mean is the patient's head needs to be above, or their ears, the external ears or the earlobes should be above the shoulders. So somehow you've got to get them, we call that ramping up.
Mm-hmm.
So if you can get them in that position, or if you can even get them at a 30-degree angle or setting up just a bit, then you can kind of optimize the way that you're going to position the head on the neck and then the head on the body. So the first thing you do is you ramp them up. You make sure they're at that optimal angle and that external ear is above the shoulders. Now you've positioned the head on the body. Now we can position the head on the neck, in which we push that head back.
Mm-hmm.
And when you have that trauma patient where you cannot position the head on the body because you can't bring that head back, you still have some ability to have some mobility of the external airway in the anterior portion so that you can get that tube placed.
Yeah. Yeah, I remember back in paramedic school, what you're saying, it's a little bit different than the way that I did it back in paramedic school,
Mm-hmm.
which was hyperextend the head back as far as I could completely get it.
Right. So by default, you got there.
Right.
But it was much harder. And then those of us who, everybody has varying difficulties in their ability to just, those big guys could take those heads and to take the laryngoscopes and just manually make this airway into their way. Those of us who don't have as much upper body strength, it's more finesse.
Yeah.
So yeah, positioning's kind of 9/10 of the law. You can make an intubation look super easy, even though it's super difficult, if you just position the patient and take that extra time. And it's worth it. It pays off.
Yeah. I learned when I first started off, I relied on muscle to be able to, I'd pick their head up off of the table,
Mm-hmm.
and I relied on muscle. And by the time I'd done a number of intubations, I realized there was a lot more technique involved. And then I went through some advanced airway training, and I watched a doc use 2 fingers on the laryngoscope and on the handle, and that just blew me away, because when I released the laryngoscope, I had a 2-inch indention within my palm.
Or a bruise.
Yeah,
I've seen people have bruises.
exactly.
Yeah,
it was all about muscle at the time.
So
Okay, so preparation, very important. Positioning, very important as well. Let's talk about pre-oxygenation.
So pre-oxygenation has come a long way since you and I first got into this. I mean, before it was bag, and then get that oxygen up as much as you can, and then we can go in with the dagger and try to get the patient intubated. Pre-oxygenation has had a plethora of literature and studies on what makes this patient, getting that patient to the optimal oxygenation to make sure that we're ready to go ahead and start intubation. The key is to prevent the DSAT time. The other key is to prevent the number of attempts that you intubate your patient.
Mm-hmm.
All of those things pertain to worse outcomes. And so by knowing that, I think it's extremely important. It is not ingrained into the paramedic education that you understand that if I try to intubate a patient 6 times, that they'll have a worse outcome. Although we feel like you should know that, but now we have the research to prove it. For each time that you try to intubate this patient, they have a worse outcome.
Okay.
And so the key is get that oxygen up as much as possible, so that first attempt you can take some time. Obviously, there are those patients that you can't.
Yeah.
And so, but pre-oxygenation, the key is to give them as much as possible. If the patient's on CPAP and it's getting their oxygen up, you have them on 100%, leave them on the device. If the patient, if you can get a nasal cannula on and just turn it up as high as you can get it, you can also put a non-rebreather over that and just turn it up as high as you can get it, as long as the patient's actually breathing with that extra non-rebreather, that's helpful. But there's also passive aptic oxygenation, and that's just diffusion as you and I know it. So basically oxygen will go from higher to lower whether you're breathing or not.
Right.
So if you flood them with tons and tons of oxygen just by that nasal cannula, then even the least experienced person's going to get a couple, 2 or 3 extra minutes for intubation. If the patient has no lung disease, with lung disease, it's questionable as to whether that will work or not. And that's why I say if you had them on CPAP and they're oxygenating okay, but you still need to intubate them because of their mental status, leave them on the CPAP until it's time to put the blade in.
Okay. So, when I first became a baby paramedic, I know that was always a very stressful moment. The minute that I pulled the mask off of the patient and entered into the airway. Learning what we've been learning over the last few years with that apneic, say, hyperoxygenation that's been happening naturally, it should put us at ease because they're not going to desat near as fast as what we've, what our mind is telling us at the moment, right? So we can really slow down and pay attention to what we're doing and pay attention to passing that tube right the first time.
And making sure your blade's in the right spot and such. Yeah, absolutely. Yeah. And if you do the 2 Ps before that, preparation and positioning, then, you have that extra time now, and you will also be faster with your first pass. Yeah. So you'll move a little bit faster and you'll feel more confident.
Because you're not kind of beating them up and having to make all of those different adjustments, right? Right. Yeah, makes sense. Okay, so pre-oxygenation. So pre-treatment.
Pre-treatment. Okay, pre-treatment has also had a whirlwind of advancement, and as well as understanding what pre-treatment includes. Pre-treatment doesn't just include that plethora of medicines that we all talked about a long time ago, like lidocaine and such. Pre-treatment, the first thing I want medics to think of pre-treatment as, what is my patient's blood pressure? Because if you don't know what your patient's blood pressure is, you should not be intubating them. Essentially, what I want them to understand is that when you take a patient from normal respiration, so let's take a deep breath, your diaphragm goes down and the air sucks in, and it's going from an area of higher pressure to lower pressure. And so you actually increase your venous return to the heart that way. Right. If I change that dynamic and I put a tube in you just for funsies and I start bagging you away, then all of a sudden I'm pushing air into you, not from higher to lower, but from a high pressured source. So I'm taking you from a negative, what we think of as a negative pressure ventilation, to positive pressure. And a normal person, just on a good day, if we just decided to go RSI, our partners for fun, would adjust equilibrate somewhere around 20 mgs of pressure by their systolic. Okay. And diastolic changes a little bit lower, but it will change. And then you equilibrate to the situation. Think of a non-healthy patient. Right. Think if that blood pressure is already starting out at 60 or 70. What's going to happen when I put a tube in them and start bagging them? They're going to code. Yeah. And so it's extremely important that the first thing you think of with pre-treatment is, do I need to pre-treat that blood pressure before I change them from a negative pressure ventilation or normal ventilation to positive pressure ventilation and put them on the ventilator? Yeah, because we know just with the physics and the fundamentals of respiration, we're decreasing cardiac output through that. So if what you're saying is if they're already compromised, then we're only making a bad situation worse. We're going to decrease that venous return. We're also going to hyperinflate those lungs. They're going to press on the heart. That's going to further decrease the cardiac output. So you've got both right and left heart associated decreasing. Gotcha. So that's a big deal. And so what can we pre-treat them with is the next question, right? So things that you need to kind of keep in the back of your mind, if you don't have them in protocols and you can't do anything independently without protocols, then they need to be added to your protocols. So you can add a norepinephrine drip. You can also just do a little what we call push dose epinephrine. Right. And how do we mix push dose epinephrine? Well, you take your code cart epi, the 1 to 10, what you push in a cardiac arrest. Okay. You take 1 ml out of that and you put it in a 10 cc syringe. Okay. You dilute it to 10 mLs. And then you can push an ml or 2 at a time until that blood pressure is somewhere above 90. Got it. Or at least at 90 before you take them from high pressure, or from normal pressure to high pressure ventilation. Okay. So that's kind of something new that's been being talked about is push dose epi. Right. And that's really I'm not that familiar with it. Is that really the basis of where push dose epi has been coming from, or what's been pushing that, so to speak? I think push dose epi is extremely helpful in your peri-arrest, pre-arrest, and your pre-intubation treatment. Okay. I think that's where it's kind of getting its big pizzazz. Got it. And getting patients stable. So when you come from our environment, I went from your environment to my environment where everything's locked up in a little gadget that only the nursing has access to, and now all of a sudden I don't have my box of drugs that I used to. I got to make use of what's in this code card or this crash card, and I think that many doctors, that's what they've done. Okay. And the push dose epi in itself, I mean, a long time ago, before everything had to be completely protocol driven, was used in the pre-hospital environment. You had those pre-arrest, peri-arrest patients where you'd give them 1 or 2 mLs of the 1 to 10 if their blood pressure was drifting down or they were about to code again, and it worked well, and I think it probably flourished from there. Yeah. Okay. So interesting. That is one of the pre-treatments. The next pre-treatment is think about. So I want to debunk a little bit of a myth here. Okay. lidocaine in itself was used for many, many, many years. And the thought was, what do you think?
Decreased intracranial pressure.
Right. So it blunts that increased intracranial pressure in the patient that may have like stroke or head trauma before you intubate them, because intubating can cause that. And the truth is that it doesn't. Okay. It works hardly at all.
Yeah.
So most people at this point in time, it's really not worth the money that you're going to put into their veins. I don't believe it's harmful, but turns out that most of the literature says that it's not helpful at all. So I wouldn't waste my brain space on it as a pretreatment, but if you had a test coming up, I would remember it.
Yeah.
What really blunts intracranial pressure is treating pain. If I stick a laryngoscope in your mouth and a tube down your throat, it's going to hurt.
Yeah.
So I probably ought to treat your pain. And fentanyl has come around as a very good drug, 50 to 100 micrograms in the adult patient, and a weight base for the pediatric patient, has shown that if we treat the patient's pain early on in their care, when we first put them on a ventilator and then continuously throughout, that we decrease their mortality in the ICU and we decrease their number of ventilator days.
Okay.
All of that's a good thing.
And we know all of that's very important.
Right.
When you start graphing and trending days on vents, especially people with some sick disease processes, that's a really big thing.
Yeah.
And moments of hypoxia.
Right.
So we know that's a big deal.
So those are the two pre-treatments that I waste my brain space on. A little cognitive offloading. For the rest of them, just don't really matter all that much.
Got it.
You know, you can try some defasciculation dosing for other things, but in honesty, if you want defasciculation, then use a defasciculating agent. Sure. Yeah, don't waste too much of that, you know, brain space on things that aren't useful.
Yeah, right. Okay, so, well, we talked a little bit about, you just said defasciculation. Let's talk about that. Talk to me about paralysis.
So paralysis is obviously key to RSI, rapid sequence induction or intubation. There are some people out there right now who are just using a little bit of sedative, which we did miss our sedatives in the pre-treatment. So let's go over those real quick as we rewind. Sedatives, so we do need to sedate the patient, right? What sedatives are most commonly used right now?
Well, there's the whole slew going down is etomidate and then Versed, and then you go into your paralytics.
Right. So etomidate, ketamine, Versed, those are kind of your sedatives. Yeah. We need to think simple. You can't buy all of them. Some people really are on this ketamine train. I'm like, it's good. It's you know, but it's kind of pricey when you start talking about staff and ambulances with it. So if you want it, that's great. Etomidate works just as well in that whole feared, you know, adrenal insufficiency. What we know is that pretty much it probably doesn't affect them at all, because you've got some that says it has a minor effect and some that says it doesn't affect them at all. So overall, the literature really doesn't support that it's a bad drug. It's a cheap drug, so it works real well. Try to stay away from the benzos unless you absolutely have to use them, mainly because it increases mortality, increases ventilator days, increases ICU delirium. Okay. So that's the one thing I would say. Etomidate and ketamine are both hemodynamically neutral in their normal dosing. Etomidate will cause some hypotension in higher doses. So if you're having to redose, that needs to be something on the back of your mind. Ketamine can sometimes get you a favorable increase in blood pressure. So if you're playing around with the pressures and you're using the push dose pressors, you might think that might be good as well. But just remember, some of your patients, the only reason that you see that is because it causes a catecholamine surge or an adrenaline surge. If they've already exsanguinated all their adrenaline, they're not going to get that, and it is a direct cardiac depressant. And so that thing people don't realize is that it does depress the myocardium. So keep that in mind, especially in kids. So moving on to paralysis. Sorry, I skipped those in the pre-treatment. Paralysis, we think succinylcholine, vecuronium, and rock. Those are kind of the drugs that you guys keep on the truck. And they're all fairly interchangeable, if you think. You have the fasciculating, which is Sux, and then you have the non-fasciculating or the non-depolarizing, which is Vec and Rocuronium. In my mind, I would say find the cheapest one to keep on the truck that doesn't have to be refrigerated, and that's Vec. I function very well pre-hospitally with that. I still use it in the hospital. Rocuronium's around the corner if I want it. That's fine too. But ease in dosing seems to be, you know, for me. The other thing I like to think of is that, you know, these things go on back order. So you need to know all of them because they're going to have to be used interchangeably. Yeah. And so succinylcholine has some contraindications. And the primary pre-hospital contraindication is really just two. You need to think if the patient's hyperkalemic or has a predilection to being hyperkalemic, then you need to stay away from it because it can drive them up enough to push them over the edge, and you'll have somebody who's pro-rhythmic, and you can't really treat that.
Okay.
The other thing is that if you have a population that is fairly dependent on opioids, it's going to be pretty hard to keep them down.
Right.
So a longer-acting paralytic might work to your advantage.
Okay.
So you have succinylcholine dosage is 1 per kilo. Give them the full 1 per kilo. Don't half dose and then redose. When you redose on Sux, that's where you get your bradycardias, your peri-arrest situations. It's better just to go big or go home. Give them a big old dose. And then vecuronium is just a decimal point less than that. So if I give 70 to one patient of Sux, then I'm going to give 7 of vecuronium.
Okay.
And then if you think of rocuronium, it's exactly the same dosing as you think of your succinylcholine.
Yeah. Okay.
So I always like to keep those straight out in my mind. And I always say, hey, if you're going to use paralytics, just know all your paralytics. Know the one you're keeping at the moment because it'll go on backward and you'll have to go to a different one. So.
Yeah. Okay. So you mentioned Sux and you mentioned potassium. So, and earlier you took us through kind of debunking a myth. Let's talk about that for a minute. So I know a lot of times in paramedic school, when I was in paramedic school and now that I instruct, there's always that what if. So what if we run the burn patient, a bad burn patient, and they need to be intubated. The student, many times we think of that 1 in a million scenario. Is that going to be an issue to intubate that patient because of some potassium issues?
It's actually not. That is on the long term. So that's the patient who's been in the burn unit for several months, up to 3 months before they'll even consider it a major issue.
Okay.
But mostly, within that first month, they'll start considering not using it. Most burn units don't use it because their patients are there forever.
Yeah.
They're in the burn unit. But for pre-hospital, that is not a contraindication at all.
Got it.
Many of the contraindications that you hear about, so you definitely want to use it with caution. And anybody who has a predilection to having high potassium, or anybody who has neuromuscular disease, or if the patient's overdosed on anticholinergic.
Okay.
Such as weed killer or whatnot. So if the patient, is salivating and all that good stuff, stay away from it because you essentially used a long-acting paralytic because the same receptor to breakdown has been blocked. So it'll last forever.
Yeah.
So.
Okay.
But yeah, pre-hospital,
good to
not
go.
really an indication.
Not an
good
issue.
To go on that.
Good deal. It's good to know. What about placement?
So for placement, the key is to have you practiced and what are you going to use. So this is when we start thinking about what's plan A, B, C to X, right? So we start thinking about what blades are we going to use? What blade is my favorite? I always like to tell the paramedics, especially students and then those who are practicing, if you have a blade where you're like, this is the blade I always use, you're not 100% at placing your tubes. Each blade is designed for a different patient and a different situation, and you should know how to use all of your stuff. Because that's how you identify, okay, this isn't working on this patient. And the definition of insanity is doing the same thing over and over again and expecting a different result.
Yeah.
So let's make sure that we make an adjustment. So you get in there, let's say that first pass, you couldn't visualize the cord. Something was amiss. So during your practice, you'll have identified, okay, when I get in here with this blade, let's say I get in there with a curved blade, and this is a trauma patient, and I can't really get a good view because I don't have a lot of mobility, then I'm either going to go over to my hyperangulated camera or I'm going to get the straight blade at them. So I'm going to make an adjustment before my next attempt. I'm going to pre-oxygenate again, and I'm going to make an adjustment for my next attempt.
Okay.
The other thing is that some people are teaching that you should immediately go to camera intubation, and that's not a good thing. That should not be your only tool in your toolbox because, again, hammer to nail, we want to make sure that we're keeping an eye on what we're doing and that we have different tools for different reasons. And the camera is not an underwater diving machine. And so when Mount Vesuvius erupts and you've got blood or vomitus or chunks, it's not going to see through it.
Right.
So you definitely need to know how to use your direct laryngoscopy. So bimanual approaches, some people will use that and they'll do that backward, upward, rightward pressure.
Right.
And that'll help kind of pull things into your view. You've made the adjustments beforehand, so you've prepared them by positioning and pre-oxygenation. So that should get you to the point where placement is a little bit easier.
Yeah.
Now, when we talk about placing, what are you going to place? You want to place a normal size tube. You don't want to place the largest tube that they could possibly handle. There are complications downstream of that, and so we would ask you not to do that. But we would also ask you not to place the smallest thing that you could put into them because we have airway issues,
Yeah.
and we have obstruction issues, and we have ventilator issues downstream of that as well. So I usually say if you have a normal size male, 8, a normal size female, 7.5 to 8.
Okay.
Usually it's about the right size tube.
Okay.
So that is placement.
Okay. Now, so we've gotten through a lot of stuff here. So we just talked about placing the tube. So sometimes you hear people say, let's land the plane. So let's talk about that. Let's talk about post-intubation management.
Yeah, so sometimes you get that tube in, and you're like, this tube's in, drop the mic, walk out of the room. No. Like, we're still putting the plane on the ground,
Mm-hmm.
We just started to descend once we have that tube in.
Okay.
Your biggest complications are actually going to happen after the tube's in.
Okay.
So you have to understand post-intubation management. Number one, how did you confirm your tube? I consider that as part of my post-intubation management. So how do you confirm your tube when you're out in the field?
So everything from visualization,
Mm-hmm.
of course, listening to lung sounds and
Mm-hmm.
belly sounds, and then entitle.
Right. And then
Color changes.
you can do color changing, or you can do the entitle capnography,
Right.
which we hook up to our machine. And both are wonderful, but the continuous capnography seems to be where we're headed
Mm-hmm.
towards. I'm a big proponent of that. Make sure that you're putting the right size. I see adult ones used on our micro little itty-bitty things.
Oh.
That creates a breathing circuit, so we want to make sure that we're using the right size device that's designed for them. So yeah, definitely listening, seeing the tube past the cords
Mm-hmm.
is huge. And then once you start changing them and you start ventilating them, you need to start thinking, where's my oxygen saturation and where is my CO2? And then how am I going to keep them sedated? Ketamine's probably a great drug for this, because you can snow them out with about 100 and they're good for the trip.
Yeah.
And if you have a long-acting paralytic, everything's good because you've already given their pain medicine. But you can also bump them with a little fentanyl if they start to bucket your tube, just slowly titrating up the sedation.
Mm-hmm.
Etomidate works good too at small pushes. I know you guys don't do drips, to sedate patients.
Mhm.
So you want to think of large boluses to keep them down. And if you're having some difficulty keeping the patient under control, then you want to go, well, I just need to give another paralytic
Okay.
and then some more sedation.
Okay.
Because they're kind of out of their gourd. You need to control the situation.
Yeah.
And giving a little extra paralytic's not going to harm them. Just make sure you're using a long acting and not a sucks, because at that point in time, that doesn't make any sense.
Yeah.
Right? So you've identified your placement, you've got your color metrics going on, you've got your pulse ox on, you've identified what you're sedating them with post-intubation, you're rechecking your blood pressure,
Mm-hmm.
your heart rate, and your pulse oximetry. And I always like to say, well, what happens once you get the tube in and the patient's pulse ox goes down and not up?
Mm.
Right? That happens. So you get the tube in, you start ventilating them, and you go, uh-oh,
Mm-hmm.
now this didn't fix it like I thought it was going to, right? So the first thing you do is you set them up.
Yeah.
Okay? Set them up. Turn your oxygen. Make sure your oxygen's turned up or turned on.
Yeah.
Many times that doesn't, it's not on. So make sure it's turned up and turned on as high as it'll go. Set them up. And then the next thing you do is positioning. So you've set them up. They're still not going up like you thought they should.
Okay.
Or they only go up minor and then they start tanking again.
Okay.
The next thing that you should do is suction.
Okay.
Run a suction catheter down that tube. Make sure it passes.
Okay.
If it doesn't pass, then maybe that tube's curled up. Maybe you use something smaller. Maybe it's an old tube that was kind of crushed in the pack for a while.
Okay.
So make sure it passes. If it doesn't pass, take your introducer. It's a little bit more rigid and pass it through that tube
I got it.
so that you can undo whatever is kinked.
Yeah.
So now you've got, this is all dependent on the fact that you still have some capnography running. You've got
Mhm.
CO2 coming off. So you want to make sure that you're not in the wrong place.
Yeah.
So now you've done that. You've passed the suction catheter. You've made sure your oxygen, everything's on, but it's still not doing well. Well, it's time to percuss. And I always tell people, okay, now it's time to percuss. So you put these towels on the anterior portion of the patient's chest, and you take your hand and you cup it, kind of like a little cup, and you just kind of start playing the drums on their chest, back and forth. And you do it one side and then the other side, and then you raise their arm up, and then you wait a little while, see if they start to recover. If they don't, you turn them to the left. If that doesn't work, you turn them to the right. You got to give each step that you do a minute or two to see if it's going to work.
Okay.
So I know people who are rushing through the steps because I tell them these are the steps you take. So they set them up, and then they immediately go to the next step. It's like give it a few minutes and see if they equilibrate.
Yeah.
Setting up, when you lay a patient down, they lose about 25 to 50% of their lung volume.
Okay.
Especially if they're obese.
Oh,
Normal people, 25%. You'll lose that. We
Yeah.
lay back, we lose 25%.
Right.
Gravity helps, and our
Yeah.
innards start pushing up on our diaphragm, so we lose some lung volume. Just by setting a patient up, you can gain back 25% on a normal person. Morbidly obese, up to 50%.
Sure.
Right? Because there's more girth in that abdomen. So just by doing that, you get more oxygenation and perfusion, so you're getting more lung volume there. The other things that we're looking at is mucus plugging and things like that. So also make sure that you're doing some butyral and atrovent through your nebulizer treatment so that you're opening things up as you should.
Yeah.
And then you can also add your PEEP.
Yeah.
Which is the positive index expiratory pressure.
Right.
And if you're tanking, you're in a bad situation, you start
Adjust
dialing that up.
Yeah.
That means more oxygenation, right?
Right.
So
Yeah.
there
Okay.
you go.
Okay. So that's our 7 P's.
That's
We
it.
talked about the importance of each and every one of those. We hopefully broke a couple of myths for you guys. We've enjoyed it. I want to thank Dr. Brave. This has been about 31 minutes. So thank you for joining us, and we will talk to you soon.